Hi, my name is Sarah Marasco, and I am a clinical social worker and training and implementation specialist with the Michigan Collaborative Care Implementation Support Team. This webinar today is going to talk about the collaborative care intake process, which includes triage, the structured diagnostic assessment, as well as initial goal setting. So, as we know by now, it takes a lot to get ready for launching a collaborative care program in a clinic and for being ready as the care manager to get started with this kind of work. It takes workflow redevelopment, it takes completing your training, educating your providers and your staff within your clinic, having your materials ready, which includes both your personal materials that will support you in your clinical work, as well as patient educational materials, having your panel reviews all scheduled and being trained up and ready to go for that. And then once you've done all of those things, opening up your program for new referrals. So let's imagine we're at that point and you are open for business as a care manager. Now at this point, you receive a referral to your collaborative care program. This is likely going to come from your PCP champion if you are working with someone specific in the clinic, and it's very exciting to get referral number one. But oh my gosh, what do I do now? So today we will talk about how to screen and triage and complete an intake into the program for patients who are appropriate for your collaborative care program. This is an example of a collaborative care workflow that was developed by our team. And this is just a part of the workflow right at the beginning. So we can see at the top, we're looking at identifying the eligible patients for the program, and then the PCP or any provider or staff that your clinic's identified can make that referral to the behavioral health care manager to see if the patient is eligible for the collaborative care program. So you can see beyond that step that it mentions that the BHCM conducts a triage assessment, and that is indicating whether the patient is appropriate for collaborative care services. So next we will talk about what that triage assessment looks like and how you will conduct that as the care manager. So the triage assessment is used to determine whether a patient is appropriate for collaborative care. And that will differ based on your clinic. Each clinic might have a different threshold in terms of who they refer to and enroll in the collaborative care program. It might include different diagnoses. So certainly consider those criteria when you are doing your triage assessment. It can take place via a number of modalities. That might include chart review, which could include looking at PCP notes, past treatment, prior medications, maybe scanned in records from outside providers, and things like that. It can also include discussions with providers. So you might chat with your behavioral health staff in clinic or nurses that have been in contact with the patient. You might talk with the PCP about why they referred the patient to collaborative care and what they're hoping for in terms of support with treatment. This can also include a discussion with your psychiatric consultant. This can be especially helpful in the beginning when care managers are getting used to who they might enroll in the program and who might benefit from collaborative care. So the care manager might gather information from all these different modalities and then talk further with a psychiatric consultant in their scheduled panel review time or via a quick phone call about whether they might want to try treating this patient within the collaborative care program. And then, of course, direct patient assessment can be an important part of triage, and there are certain things that can be helpful in asking patients about that can help to determine whether they are appropriate for collaborative care, and I will go over those in a future slide. And triage can take place at any time, really. It should take place at the time of referral for every patient to ensure that they are meeting criteria and getting the appropriate level of care for what their needs are. And triage can also take place later on in clinical care. Patients can change, and care managers might uncover new information throughout their work with the patient. So just remember that it's an ongoing process, and the care manager should always be wearing their triage hat and ready to refer the patient elsewhere if they might benefit from a different service, more so than collaborative care. So I did discuss this during our collaborative care overview webinar, but just briefly, I wanted to touch on who might require a higher level of care than collaborative care. This can often include patients with severe substance use disorders, such as those requiring inpatient treatment or detox, patients with active psychosis, severe developmental disabilities, or personality disorders requiring long-term specialty care. This can also include current CMH, community mental health consumers, or persons requiring that level of service. And we say this because patients who are engaging in a collaborative care program need to be able to complete outcome measures on a regular basis, as well as to engage with a self-management plan and to be able to be served in a program that is time limited. So we often find that folks who meet these criteria might benefit from a different level of care than collaborative care. That being said, like I mentioned before, your organization or clinic will have established criteria for who you want to treat within your collaborative care program. So definitely keep those things in mind when you're triaging your patients. This is the triage assessment that we recommend for determining whether your patients are appropriate for the collaborative care program. This can actually be found on our website in a document titled BHCM Intake Checklist, which is available on our Care Manager training page. So there are a number of things that we're curious about that can help to determine whether a patient meets criteria for collaborative care or whether they might fall into one of the categories I mentioned on the prior page, which could determine that a different level of care could be more helpful to them. So we're curious about presenting symptoms of concern as well as their psychiatric treatment history. We want to know whether the patient has been a CMH consumer in the past, whether they have a diagnosis of a psychotic disorder, and whether they have a confirmed or likely personality disorder diagnosis. These aren't immediate rule-outs. Patients could certainly still be treated in the collaborative care program if they have something like this documented or reported, but this is good information for us to have in terms of our decision-making for whether to enroll the patient. We would also like to know about a history of psychosis or hallucinations, whether auditory or visual, so not just the diagnosis, but whether there's been any report. Knowledge about prior medications can be helpful as well. This can be indicative of prior diagnoses or symptoms. We might be curious about mood stabilizers and antipsychotics in particular. And lastly, we, if possible, would like to administer the core outcome measures to learn some further information about our patient. The Audit C helps to indicate level of alcohol use, and a high-risk Audit C score could indicate whether the patient's alcohol use could warrant inpatient or residential treatment instead of collaborative care at this time. And in terms of the PHQ-9 and GAD-7 scores, that will vary based on the criteria that your organization or clinic sets. For example, some decide to only enroll patients in collaborative care that have either a PHQ-9 or a GAD-7 score that is 10 or greater. So we included this item to say that maybe if your organization decides to follow this type of criteria, if your patient has a score of less than 10 on both the PHQ-9 and GAD-7, that might indicate that they could be triaged elsewhere to a different program or level of care. Referring back to the workflow document, we can see that we've conducted the triage assessment as the care manager, and now we're thinking about whether the patient is appropriate for collaborative care. So if no, you can see that the care manager then refers the patient to an alternate service or back to usual care with their PCP. No matter what they do, they want to notify the provider who referred the patient, as well as the PCP if the referring provider was a different person, and then to document what happened during the triage assessment and what the decision making was. Now, if the patient was appropriate for collaborative care, we want to move on to whether they agree to services. So, with this, we want to think about how we pitch the collaborative care program to patients. How do we describe it? How do we talk about it in a way that they know what the program will look like and what might be expected of them? On our website, under the Behavioral Health Care Manager training page, we do have a document available titled Introducing Collaborative Care, which helps the care managers to formulate their pitch, both to patients and to providers, in talking about the collaborative care program. This is something that is definitely worth practicing prior to doing your first enrollment of a patient in collaborative care, and it can take a balance between making sure that you include the necessary information as well as making it feel comfortable for you in terms of your clinical style. So take some time to review this document and practice, and maybe even keep this posted at your workstation so it's something that you can reference, particularly when you're a new care manager. And as part of those who are working with our implementation team, we can certainly work together to role play this pitch and to make sure that you feel comfortable with it and practiced up before you start enrolling patients. So you have pitched the program to the patient and talked about what their role will be in the program and what you hope to provide as part of being their behavioral health care manager. And they have agreed to services. Congratulations. So at this point in time, you will need to receive and document consent into the collaborative care program. This is important so that the patient knows what they're agreeing to. And also, when you begin to bill for collaborative care, this is something that will need to be documented in your EHR in order to bill. Consent can be verbal or written according to CMS guidelines, and it does need to be documented in the EHR before collaborative care services begin. Some key items that need to be included in the consent include permission to consult with the psychiatric consultant and relevant specialists, any billing information such as copays, if applicable, and that disenrollment can occur at any time. And if you are billing for the services, mention that disenrollment would be effective at the end of the month. Additional information about consent is available on our website, including information in our EHR guidelines document in terms of how to set this up within your EHR to make sure that you have the right language and recommended checkbox available for documenting consent into the program. So once you have received and documented consent, it's time to move forward with conducting the structured diagnostic assessment. So within this diagnostic assessment, we want to learn about both the present and the past for this patient. We're curious about their symptoms, their diagnoses, the treatments that they've undergone, any pertinent psychosocial details, their coping skills, some that they've tried that have worked or haven't worked, as well as their strengths and their goals. Before we move into the assessment, we want to address any questions and help them to prepare for it. You know, we've been talking to them quite a bit already. We have consented them to the program, and it can feel like a lot of information. So we do want to check in and make sure that this feels like a collaborative process. I've shared a suggested statement that you can say to the patient, and you can obviously tailor this to your own style. So you might say something like, so far, we've talked a bit about what collaborative care will look like, including your role, my role, and the other team members' roles. You've also shared a bit with me about what's been going on with you. Given everything we've talked about so far, I'd like to check in regarding anything that might be on your mind. Then, when you're ready, we'll move forward and I'll ask some standard questions to learn more about you and what we might focus on throughout our time together. So think about whether that might feel natural for you to adopt and incorporate into your work. And then you'll also want to set expectations for the patient and provide some choice. It's good for this to feel collaborative and to make sure that they have a say in what's happening in their treatment. So let them know that the diagnostic assessment takes place either by telephone or face-to-face, and that it can be about 30 to 60 minutes on average. And this can allow the patient to budget the appropriate amount of time and to determine whether that's something you can dive into right now or whether you might want to schedule a separate time to do the assessment. And you can offer to the patient, like I mentioned, whether they want to do this by phone or face-to-face, and let them make the choice based on what feels right to them, and giving that flexibility in case, for example, they have a hard time making it into clinic, then you can do it by phone. So now we'll start moving into the information that you'll want to gather in your diagnostic assessment, and know that this is a lot of information. And so we'll get as much as we can in the initial contact with the patient, but remember that assessment takes place over time, and it might take more than one contact to gather all of the information that you need. So just keep that in mind and do the best that you can in that initial contact with the patient. By the way, all of this information is, again, available on our website in a document titled BHCM Intake Checklist, and that's the same one I mentioned earlier that's available on our Care Manager training page. So all of this will be summarized in this document, and you can actually print out the checklist and keep that in front of you at your workstation to look at and reference while you are working with your patient. So when we're talking to a patient, we might just start with their presenting symptoms of concern. We want to know why they're here talking with us today and why they were referred to the program. We've shared some sample statements here again. So you might ask the patient, what made you decide to talk with me today? Tell me more about what's been going on. Or even acknowledge what they've shared with you already, because they may have brought something up in your prior conversation. So you've mentioned you've been feeling down. Could you share more about how that's been impacting your daily life? We want to keep these questions very open. We structure our intake and our assessment in the style of motivational interviewing, as we know that can really build good rapport with patients and help us to establish a good relationship and get good information in terms of how to move forward. Outcome measures are an important part of the collaborative care diagnostic assessment. We know that this is a treatment to target measurement-based model, and so these are key for understanding where our patients are starting and for assessing their progress throughout our work together. So it's important to get these baseline outcome measures as well as to continue gathering these throughout your patient's time in the program. So that's exactly what we want to explain to our patients. We want to let them know that we care about how they're doing and that we want to take a look at these on a regular basis to make sure that what we're doing is working. We might say something like, your mental health is an important part of your overall health. Just like your PCP regularly monitors your blood pressure, we want to regularly monitor these symptoms so we know what progress you're making. These measures help us to know if our treatment is working. And if it's not, then we'll know as soon as possible, and we can decide together if some changes might need to be made. In the spirit of collaboration, we can also give the patient the choice as to whether they'd like to do those measures right off the bat at the beginning of the contact and knock them out, or whether they'd like to wait and talk a little bit first before they dive into completing these. Now, you may have gathered some of these measures already in your triage assessment. I had mentioned the PHQ-9, GAD-7, and Audit-C. If you haven't gotten those yet, go ahead and get those during this diagnostic assessment. And the CD-based bipolar questionnaire can be helpful as well for screening for risk of bipolar disorder. And the MoCA can be helpful as indicated for looking at whether a patient might have some cognitive decline or memory issues. This can be particularly helpful if you're working with older adults. And we can give some training in administering each of these measures, and they are also all available on our website. So we know that thoughts of death, harming oneself, and thoughts of suicide and prior suicide attempts can be common within the collaborative care population. Our care managers should always be assessing for these thoughts, and it will also come out on the PHQ-9 oftentimes when patients are answering the number 9 question on that outcome measure. So, when clinically indicated, risk assessments and safety planning should be completed. Care managers should be well trained in both of these processes. They'll want to consider their organization's suicide protocol, which might help determine when and how you could refer to a higher level of care or involve crisis services in your area. In terms of further training, resources are available on our website, and we also recommend role-playing this with either an internal clinical supervisor or a member of our team, just so you can get really comfortable with completing risk assessments and safety planning so that you're ready to jump right in, not if, but when the need arises. So we're also curious about the patient's behavioral health history, which is something that we've sort of touched on a little bit in some of our questions so far, and the patient may have already disclosed some of their history to you. We're very curious about the course of their illness. So say a patient is talking to you about depression or anxiety. We want to know if this is something that is a long-standing issue and they've had a chronic course of this illness or many episodes, or whether this is their first episode. We also want to know if this is something that was brought on by an acute issue, such as a job loss or a death, or whether this is something that seemingly came out of nowhere. So there's a few questions here that you might ask your patient to get at these types of things, such as, how long has this been going on? Is this something that's always present for you, or does it come and go? And what tends to bring on these feelings, if anything? We also want to know about their diagnostic history, so what types of mental or behavioral health diagnoses they've received from a healthcare provider, and if they have received any, who was it that made that diagnosis? For example, was it a social worker, a therapist, a psychiatrist, a PCP, and when did they receive that diagnosis? Again, we do always want to be screening for a history of psychosis. This is something that should have been done in the triage assessment, but we want to be asking the patient whether they have ever had any experience of auditory or visual hallucinations, such as seeing things that other people don't usually see or hearing things that other people don't usually hear. Lastly, it is always good to practice trauma-informed care, and we do want to be aware as to whether a patient has a trauma history. So it often can be appropriate to wait until a trusting relationship is established before screening for trauma, as we don't want to re-traumatize our patient, and it can be good to build rapport. That being said, there are some screening tools that can be used in your settings if you are suspicious for trauma and if patients are reporting symptoms consistent with PTSD. These screening tools include the PC-PTSD-5, which is a screening tool that's been updated to reflect DSM-5 criteria for PTSD. And there's also the PCL-5, which can be used in primary care settings as well. These two tools are available on our website, and you are welcome to reach out to our team if you have questions about their use and would like some training in administering these measures. So much of this structured diagnostic assessment is to aid your case presentation that you are giving to the psychiatric consultant during panel review. So with that, medication treatment history is very important. We'll want to know about current and past medications that patients have taken, both the names and the dosages. So they might not know all of this information, but get as much as you can. We also want to know who prescribed the medications. Were they prescribed by a psychiatrist or a PCP, for example? We'd also like to know the length of the medication trials. This can be important to know because, for example, sometimes patients will have a long list of medications that they've taken in the past, and when we ask about how long they've been on them and what their dosages were, we might find out that they never got a full therapeutic trial of any medication. Rather, maybe they stopped the medications all after a few days because they didn't like the way they made them feel or didn't get up to a therapeutic dose. So some ways you can ask about that are simply asking how long you took the medication for, or maybe what made you decide to stop the medication. And with that, we also want to find out for each medication that patients have taken or are taking, what the effectiveness was of each one, and any side effects that they may have experienced with each one. So you can ask things like, what did you notice when you took that medication? Was it helpful? Why or why not? And what side effects, if any, did you experience? And lastly, it can also be helpful to understand what patients' perceptions and beliefs are about medications. Some are very open and interested in taking medication for their treatment, and some may not want medications to be a part of their treatment plan. So it can be helpful to ask about this in a non-judgmental and open manner. And then if patients are interested in learning more, as the clinician, you can ask permission to share more information and then do so at that time. We also want to be curious about the patient's treatment history in terms of therapy, and that can include anything that they may be engaged in right now or have done in the past. So we'll want to ask where they've engaged in therapy, as well as what type. So whether that's cognitive behavioral therapy or trauma focused or anything else. And patients might not know the name of what they've done, so we can get at that by asking, what kinds of things did you work on and what did you learn? We also want to know how long they were engaged in therapy, whether they went for just a session or two, or whether this was something that they really stuck with and went to for quite a while and did a full course. And then lastly, we want to know about the effectiveness. Did they find it helpful? And we can ask in an open way, what was helpful about therapy and what wasn't? And that can actually help us understand what some of the patient's coping skills are and their strengths, and it can help to guide what kind of things we do in our brief interventions with patients. Now, substance use is also a very important part of our diagnostic assessment, and it's something that can get missed sometimes. People might forget to ask about it or not screen for it because it can be intimidating to know what to do. So our care managers are trained in SBIRT, as well as motivational interviewing. We highly recommend that, so that they do feel equipped to know how to handle substance use when it does, reveal itself throughout the diagnostic assessment and their work with patients. And this can also be obviously a very sensitive subject. Your patients may have received some judgment from other providers or anyone in their life surrounding any substance use that they might engage in. So this is a really unique opportunity for you to join with your patient and build strong rapport. So when we're approaching this topic, we want to make sure that we really engage with the patient and have started to develop a collaborative relationship. And it can be a great idea to ask permission before you jump into this topic, and always try to maintain a non-judgmental air about your questions and your responses. So in terms of asking permission, you might say something like, would it be okay if I asked you a few questions about how you use substances? And that can really make it more of a collaborative conversation and give the patient some sense of control to allow you to move forward with that screening. So we want to be curious about both current and past substance use, and we can inquire about alcohol, any drug use. You might inquire specifically about marijuana use as well. Patients may or may not categorize that as quote unquote drug use, so we can ask specifically. And screening tools can also be helpful at times. I have mentioned the Audit C already, and that's something that we like to use to screen for alcohol use. And there are a number of other screening tools out there. Your organization may use the full audit, for example. There's also the DAST, D-A-S-T, for screening for substance use as well. So it's really up to you what you'd like to use. But again, the Audit C is available on our website. We also want to be curious about treatment history. So if they do disclose any current or past substance use, we want to ask whether they've received any support around that, whether those be mutual support groups or more formal treatment, such as individual therapy or any rehab or detox, and make sure to ask this in a sensitive manner. And then if it feels appropriate, we can also move forward to try to gain an initial understanding of how they feel about their substance use. So patients, this isn't new, for them to talk about if there is something that they're disclosing. And the thing is, they're the expert on their lives, and they've been thinking about this. This isn't new information, and they probably have some feelings about their use and how it impacts them. So again, if you have a good rapport, feel free to consider asking how it impacts their depression or their anxiety, or what they notice about the effect it has on the poor sleep that they've disclosed so far. And if patients do seem to be in a place where they're not ready to make any changes or not really willing to talk about it, we might just reflect that and show that we aren't judgmental of this right now, and know that we are able to plant seeds and then to discuss this further in the future if it's deemed clinically appropriate. So a reflection for a patient who's more, pre-contemplative and not willing to make changes might be, you're not worried about how this is impacting you right now. And just let that sit. And the patient may, argue with that and say, no, actually, maybe I am a little bit worried, or they might agree with you. And it's okay. You can move forward in your assessment and you can make a note of it and possibly revisit this later on. And just one additional note about substance use. Of course, if you are immediately concerned for the patient's safety, such as this coinciding with any expression of thoughts of harming themselves or, putting a child in danger, for example, that is certainly something that you will need to take action on as a mandated reporter, which we can talk about in a different training. So I just wanted to note that, if you're letting something lie, certainly ensure the safety of your patient as well as any dependents around them. So psychosocial details are also going to be an important part of our assessment, as we know that these can play a huge role in patients' well-being and their mood and overall functioning and ability to even work through their self-management plans. So there are a number of things that we'll want to talk about, and that can include the patient's support system, so who they're relying on for their everyday life, but also maybe who might support them in their self-management plan and working on some of these goals. It might be important to know about any financial issues that the patient has and whether these are contributing to their mood. Disability and work status. So is the patient currently working or are they unemployed? And if so, are they receiving disability or do they have anything pending in terms of a disability application or an appeal? It can be helpful to understand the patient's transportation situation. So that can impact whether they're able to come in and meet with you, for example, for an appointment, or whether it might be, better to talk by phone. Their living situation generally can be helpful to understand as well. So are they, in a safe place? Are they homeless? Do they have a roof over their heads? And who are they living with? And what's it like at home? And then lastly, access to a phone can be really important to ask about too. Knowing that collaborative care can be largely phone-based, this is a really great thing to understand, especially for when we're trying to monitor patients in between their appointments to see how they're doing. And some patients might have limited minutes for phone-based care management contacts, so it can be helpful to ask about that specifically. And some of you who are practicing collaborative care in rural areas also run into the issue that patients might not have good cell phone service at their homes. So that's another thing that can be helpful to ask about, knowing that you might want to follow up with a patient and just to find out what's going to be realistic. So in this assessment, we also want to be curious about what the patient has already tried for managing their symptoms, either currently or in the past, and what knowledge they have about their symptoms and their diagnosis, and what ideas they have about what they want to do. So we want to keep coming to the table with the perspective that the patient is the expert in their own lives. And with this, we like to use an approach called elicit, provide, elicit, which is from motivational interviewing. So it's a pretty simple approach, and we can practice this more in a motivational interviewing training. But basically, all you want to do when you're, hoping to learn about a patient and share some information is first elicit what they already know about something. Remember that patients have knowledge and they have ideas, and it can really help that collaborative relationship and to build some engagement to find out what they already know about something before we tell them what we already know about it. So after you've gathered a patient's ideas, then you are a trained clinician and you do have some really good ideas to share. I bet that's the case. So you've elicited the patient's ideas, and now it's appropriate for you to provide some ideas, but only after you ask permission. So you might say something like, "Thanks for what you shared. Would it be okay if I shared a little additional information about X, Y, and Z?" And then once the patient's given you the go-ahead, which they typically will, you can provide that information that you've been trained to provide. And then lastly, you might elicit the patient's response. So you've given all this information and you might just say, "So what do you think about all that?" Or, "Given what I shared and what you shared, where do you think you might go from here?" So it's a pretty simple approach, and we can certainly keep practicing it, but it's something to think about integrating into your assessment even as you start to approach topics like self-management and knowledge and ideas. So in terms of patient self-management, we want to be curious about what they've tried in the past and what they're currently trying for managing their symptoms. So you might ask something like, "What have you tried so far that's been helpful?" Or even on the other end, "What have you tried that hasn't worked so well?" And when we're thinking about elicit, provide, elicit, you may or may not provide further information right here. So remember that we're still in the assessment phase, we're gathering information, and we're not quite to treatment planning yet. So you can hold on this information and then later on ask permission to provide some, or if it feels appropriate and they do give you some information right here, you can go ahead and ask permission and say, "Would it be okay if I gave you some ideas?" and provide some here. But just remember, you don't have to do it all right now. We can gather information, kind of get a good base from where to work, and then we can do some treatment planning and self-management planning later on in this interaction. And then in addition to past self-management strategies and current ones, we want to understand what knowledge the patient has about their symptoms, their diagnosis, and or treatment for those symptoms. So we might ask something like, "What do you know about depression and how it impacts people?" Or, "What do you know about treatment for depression and anxiety?" Or even, "What kinds of things have you already been thinking about trying?" So the kind of neat thing about the elicit, provide, elicit approach is that it can also save you a lot of time as a provider. We might be inclined to share all of the information that we have about a treatment for something, when in actuality, the patient might actually know some of those things already. They might have a family member who's been treated for depression, or maybe they've been through this before. So if we can gather their information about what they already know, then it has two benefits. Number one, the patient feels like it's more collaborative because you're asking them what they already know and respecting them as somebody who has knowledge they're bringing to the table. And number two, it's saving you some time. You're not repeating something or telling them something that they're already aware of. So it's a win-win. So at this point, we've gathered most of the information that we need to help us at least move into the initial treatment phases of collaborative care. And all of this information should support you in your case presentation to the psychiatric consultant in your next panel review. So now we can start moving into self-management planning and at least start discussing initial goal setting. So you may have been talking for about a half an hour already, and it can be a lot of information that you've gone over. So it can be helpful to go over a summary about what you've talked about, and then that can help you to transition into a discussion about goals. So here's an example of a summary that might be helpful to you. "I've been able to learn a lot about you, including your history with depression, what you're currently struggling with, and some ideas that you have about where you'd like to go from here. You mentioned you're curious about medications and that you've also been interested in getting out of the house more. If you'd like, we could talk more about some self-management goals and treatment that might feel right to you. Where would you like to start?" So you'll notice in this summary that we are acknowledging some of the specific things that we've already learned about the patient, including that they're curious about medications and that they're thinking about getting out of the house more. So that's really showing that we've been listening and that we are respecting the ideas that they are already bringing to the table about where they'd like to go. And we're asking permission as well. You can see that language. If you'd like, we could talk more about some self-management goals that might feel right to you. So it's very patient-centered. We're checking in with them about whether it's okay to move forward, and then we're asking them where they'd like to go from here. We're really empowering the patient with language like this. So then we can provide some psychoeducation as appropriate. So this will bring us back to that elicit, provide, elicit approach that I mentioned earlier. So at this point, we know some of the information that they already know about medication and what they've tried and what they've found helpful, but maybe we've kept it in the back of our minds that there's a little bit more that we'd like to make sure that they're aware of before we move forward in developing a collaborative treatment plan. So we might say something like, "You're familiar with medication as a possible treatment for depression. Would it be okay if I shared some more information about treating depression?" So that could allow us to give some more information about medications or different approaches such as exercise and looking at sleep hygiene and, so many of the other things that can go into depression treatment. And so oftentimes when we're talking with patients about treatment for these typical mood disorders, we're going to want to give them kind of a menu of options, and that can allow them to, choose what sounds right to them and to feel invested in where they're going to go first with their treatment plan. So we might offer things like behavioral activation, problem solving. We might talk about psychotherapy as a referral option, medication management, and additional self-management strategies, again, like exercise or practicing deep breathing skills and things like that. So we can explain all of these things in sort of the layperson's language and kind of break it down for patients. And, you can tailor it to each patient based on the information that they've already given you in their assessment so far. But providing a menu can really allow the patient to feel invested in their plan. And then after we've given that education about their treatment options, again, elicit, provide, elicit. So we want to lastly elicit the patient's goals. So we might just say something like, "Given everything we've discussed, what do you think you might like to try?" And the patient will give you some ideas about where they'd like to go, and then you can get more specific in your steps in terms of treatment and where you'll go within the next few weeks together. So at this point, you have completed your structured diagnostic assessment, and you have talked about some initial self-management planning and done some initial goal setting, which is great. You have the necessary information to start treating the patient within the collaborative care program and to support you in your case presentation with the psychiatric consultant in your next panel review. So you might acknowledge to the patient that this has probably felt like a lot of information. It's probably been a long contact, or maybe it's been spread out over a couple of contacts. So feel free to elicit any questions or feedback that they might have about the program or this process or what's to come next. Discuss next steps. So you might have the patient talk to you about what they understand their self-management goals to be. You might repeat them back and clarify what you guys have already talked about. And you can even provide a written version of their self-management plan. You can ask the patient what will work best for them and kind of work with them on that format. You might also give a reminder of the upcoming psychiatric consultation. At this point, the patient already agreed that it's okay for you to discuss their case with the psychiatric consultant, but just remind them that, hey, I'm meeting with my psychiatrist on Thursday, and I'll make sure to discuss what's going on with you, and I'll get back to you if they have any recommendations for what to do next. And then make sure to discuss your frequency of monitoring and your next contact as well. So make a plan for when you'd like to speak next, and will you be reaching out to the patient? Will they be calling you? Will it be by phone? Will it be face-to-face? And also talk about how often you expect to talk with them over the next month or two, and that it might change depending on how they're doing. Contact information is a great thing to go over as well. You might want to learn about the best time you can call the patient, if you have permission to talk to others and or leave a voicemail, confirm their mailing address. If secure email contacts are something that's allowed within your organization, you can get their email address. And if you have a patient portal within your EHR, you can talk to the patient about whether they like to use that, and if so, if they would like to communicate with you in that way as well as part of your monitoring. So again, you want to meet the patient where they're at and find something that will work well for them and also allow you to provide good clinical care. You'll also want to share your contact information and hours, as well as emergency contacts, so patients know what to do if they do have a psychiatric emergency and it's outside of business hours and they need to talk to somebody or go somewhere. And lastly, you might want to share some new patient materials. So I mentioned above that you might want to provide a written version of the initial self-management plan. So you could have a copy of that printed out for the patient, or maybe you wrote it together depending on how you did this initial assessment. And you might have some other standard new patient materials like that you like to provide, such as information about depression or anxiety or sleep hygiene, or some examples of how to be compliant with medication. It all depends what you have available in your clinic, and you can tailor this to each individual patient, and you can have some standard materials that you like to share with everyone. So that was a lot of information. So let's do a quick summary of the collaborative care intake. The length is about 30 to 60 minutes on average, and it can vary based on the complexity of the patient as well as how much they're willing to share with you. And it might take more than one phone or clinic contact. You want to get as much as you can in the initial contact, but know that you want to be flexible to the patient's availability, so you might have to spread it out a little bit. You also might go to your first panel review with the psychiatrist and do this case presentation, and maybe they ask you a question that you don't know the answer to or that you forgot to ask the patient about. That's totally okay and very normal to walk away from a panel review with a few things that you want to follow up with the patient on. Also, remember your use of motivational interviewing. We recommend that care managers be well trained in this and that you continue to keep the perspective that the patient is the expert. Remember that they are more likely to engage in a self-management plan if they believe that it's important, that it is the right fit for them, and that they're confident that they can succeed with this plan. Also, you can feel free to keep in mind yourself and remind patients that self-management plans can change over time, and that's okay. You also want to remember at the end of your intake to establish next steps, go over those self-management goals, and talk about a plan for follow-up. We want to reinforce with patients that we will be following them closely and proactively reaching out during their time in the collaborative care program. So in terms of next steps with training, we want to recommend that you review the BHCM intake checklist that is available on the Care Manager training portion of our website. It has all of this information included, and you can feel free to print that out and keep it available to you at your workstation. We also recommend reviewing the BHCM clinical assessment tools sheet that's on our website, also under the Care Manager training portion. It has some different assessment techniques, including some questions by Patricia Robinson that can be helpful in gathering information. So feel free to check that out. And we also recommend scheduling live training. So that can include a call with a member of our implementation team, such as myself, to do some Q&A and then practice and role play this intake process, just so you feel really comfortable asking these questions and moving through what can feel sometimes like an intimidating process when it's new to you. And then if possible, it would be great for you to shadow an intake as well. So if you're already practicing collaborative care within your organization, feel free to check in with one of the care managers that is present there and see if you can sit in on an intake. Or if that's not the case for you, you can work with our team to see if we can facilitate you shadowing an intake with someone at our organization. Thank you for listening to this webinar today. I hope you found it helpful. If you have additional questions, you can visit our website, mccist.org. All of our team members' contact information is available on the website, so you can feel free to reach out, and there are plenty of resources available to support you in your clinical work, including further information on brief behavioral interventions and self-management planning. Thank you, and we look forward to working with you.